IBS-C is that's the subtype that's constipation predominant, okay? IBS-D is diarrhea predominant. IBS-M is a mixture, okay? So it's a mixture of both constipation and diarrhea. And then IBS-U is unclassified. Yo, what's good, marvelous peoples? Welcome back. And in this here mini series, right, in 300, hopefully by now y'all have seen session 302A, which talked about GERD. So now to continue on with the digestive disorders, right, I'm going to go over 302B, which will talk about IBS. In other words, Irritable Bowel Syndrome. This is one of the most common digestive disorders, right? It's about neck and neck with GERD, and GERD and IBS tend to have, association with each other. Okay, now it affects about 5 to 15% of the US population and about 6 to 11% globally. It also affects women more than men, and although it can start at about any age, they usually develop around, somewhere before the age of 50. And then you have medical costs that range anywhere from about $1.5 to $10 billion. So, while it may not be up there in, like heart diseases and cardiovascular disorders and things like that, it may not be as high up there, but it's still, a pretty decent amount when you think about it. It's a disorder that's not exactly completely understood, meaning, it's not something that has been, when it comes to causes, there's not been a cause yet, established. There's usually just things that happen over time. There also may be a predisposition in genetics, right? There may be like a hereditary trait or what have you that can trigger it. Not exactly completely understood yet what causes IBS. As far as what IBS is, it's basically, abdominal pain as it relates to defecation or any kind of changes in bowel habits, for at least, more than one day per week, on average over the preceding month. Some of the symptoms include recurrent abdominal pain, of course, cramping, bloating, and gas that's associated with diarrhea, constipation, or even both. Now that's going to lead me into the 4 subtypes, okay? The 4 subtypes of IBS is you have IBS-C, D, M, and U. IBS-C is that's the subtype that's constipation predominant, okay? IBS-D is diarrhea predominant. IBS-M is a mixture, okay? So it's a mixture of both constipation and diarrhea. And then IBS-U is unclassified. Causes, as I mentioned, are often unknown, and they're often, of course, not completely understood, but there have been, it typically ranges, this is probably the most common, thing that's found in IBS. There's usually like a gut to brain, disconnect, if you will, right? So from gut brain neural pathways, there's usually like a disconnect somewhere or some distension, if you will, and also altered motility, food insensitivity, and a genetic predisposition. This here is figure 15.12, potential, etiological factors in IBS. So as you can see here, one of the things I mentioned already, as you can see in this here, diagram is the communication between the brain and the gut, right? The body systems. There's a connection there, with nerves and neurotransmitters and things like that. So whenever there's a communication issue there, and that can range anywhere between like gender and sex hormones, or it could be like some dysregulation, as I've already mentioned, you got abnormal or any kind of like changes in gut microbiota. Now the gut part is, the GI tract. You're looking at altered motility, which I'm going to get into in the next bullet. I already mentioned altered, gut, flora or what have you, what I'm saying? So that's all GI tract related. And then of course you have GI symptoms that go with that, which, I've already mentioned up here. I want to go into contraction and motility issues in IBS. So the interstitial cells of Cengage, that's the main source of this process. Also you have the ESSL concept. This is a concept that I came up with on my own. I mean, to my knowledge, I don't think anyone else has come up with it, but the way I remember things, sometimes it's easy for me to come up with acronyms and just kind of think of stupid things to remember stuff, but it works for me. So with ESSL, you have basically the process of contraction and, motility. E is going to be the esophagus. So what happens when we eat food, as most of us know, our food, travels through the esophagus, And the first S is going to be the stomach, right? So our esophagus then propels food into the stomach. And then the second S is where the small intestine comes in. So once food gets to the stomach, the stomach is gonna, combine the acid with that food to help, process it and take it to the small intestine. The small intestine will then take that same food and acid and then start mixing in digestive enzymes, right? Like add chyme or what have you, and other digestive enzymes to, extract the nutrients, and then continue processing it further, for the L, which is the large intestine. Take the, leftover waste. All the nutrients have been absorbed now, so now the leftover waste is going to go ahead and, get sent out. That's, most of us already know how that goes, and, on our number 2. So it just gets sent to the rectum, and, it starts building up until our nerves, right, neurotransmitters of sorts, start to send signals saying, okay, well, we have a good amount of stool now, or what have you, so it's time to go ahead and let it out. With that, now that you understand that process, I want to go into the neurotransmitters that are involved, okay? So basically, all of these neurotransmitters are involved in the contraction and motility process. So each of these neurotransmitters has a role, right? And I wrote ASVN just to help me remember. The A is acetylcholine, the S is substance P, the V stands for vasoactive intestinal polypeptide, or VIP for short. And then you have the N, which is nitric oxide. I've spoken about that one, plenty of times on my channel, especially in the last one, in GERD. Along with, you have serotonin, norepinephrine, and melatonin, and there's a few others. These are all neurotransmitters that are associated with, our digestive and GI tract, right? Digestive health and all of that. So serotonin, I wrote 95.5 here because this is gonna kind of help pull together, the understanding between the brain and gut, the connection, if you will. Now, about 95% of serotonin is found in our GI tract, and the other 5% is found in the brain. Specifically, I want to talk about nitric oxide. Nitric oxide is, it's a neurotransmitter that helps to relax the, smooth muscle. So it inhibits the motor neurons and, aids in relaxing the smooth muscle, right? So that way food can travel, make food better transit, and also help open up the sphincter, relax it and manage, the relaxing the sphincter. That's what nitric oxide does. And really, that's what most of these neurotransmitters do anyway. They all, in their own way, inhibit motor neurons to help the digestive process. So as you can see, whenever there's a disconnect or there's, issues with neurotransmitters, especially relating to the brain and gut neural pathways typically are the most common finding in folks with IBS. We're gonna move on to common medical treatments. And oftentimes, depending on the subtype, anti-diarrheal as well as laxatives may get, prescribed to you. So if you have like IBS-C, which is the constipation subtype, that's the constipation predominant subtype, you may end up getting, a laxative that you may have to take. Miralax, Dogalax, and some of those are really just stool softeners. But, as far as laxatives and anti-diarrheal medications, loperamide is another one. I don't even know if I said that right, to be honest with you. But this is a common med that is, prescribed with folks that have IBS. Most of us know what laxatives, what their purpose is to help with constipation, help move things along a little bit, right? So that a laxative could be prescribed to you if you've got IBS-C, where, you're looking at a predominant constipation type. If you have the subtype of the diarrhea predisposition, or predominance, then you're going to be looking at likely an anti-diarrheal, right, to help slow down and inhibit certain receptors, and help also ease the pain and ease your diarrhea. A doctor will likely prescribe to you what's necessary for whatever it is that you have. And with that, we're also going to go into nutrition therapy. So I have two figures here that I would like to put up. So figure 15.13, as you can see here, this is the, so first I want to say the most common nutrition therapy for IBS is going to be the FODMAP diet phasing. It basically stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, which are basically just different types of carbohydrates or sugars that tend to irritate your gut processing sometimes, especially when you have IBS. So FODMAPs, right? as they go through the digestive tract, absorption, okay, lactase, transit time, dose, all of that. Those are the high FODMAP foods. Depending on what foods irritate you or which foods are triggers for you, reach your GI tract. It changes your gut microbiota, okay. And then after that, you then start to go down to that bottom right picture where you see H2O and gas, basically water and gas. There comes what's called intestinal distension. That'll then, start triggering certain other, issues for you. You're looking at, hypersensitivity, gut inflammation, and maybe even some barrier defects, okay? Like, for example, with GERD. Okay, so I mentioned earlier, IBS and GERD, they tend to be related, okay? They tend to be associated with each other. So, like, barrier defects, if you remember from my GERD video, if you saw that video first, before coming here, you will remember me mentioning that the LES, or the lower esophageal sphincter, serves as a barrier between our esophagus and our stomach. Intaking certain FODMAP, like high FODMAP foods, can have an effect on the LES as well. That's one of the things that's meant in this diagram by barrier defects with a question mark. It's possible, that your LES can end up, not protecting you the way that it should. Changing atmospheric pressure and then all that stuff that happens with GERD too. So, and then after that, you start looking at that last picture on the bottom is the brain, right? Then that's where GI symptoms come into play. That connection is essentially, I don't want to say severed, but altered. Definitely altered. 15.14. And this one is going to talk about the actual diet phasing, right? It's going to talk about the foods that's not recommended versus foods that are recommended for folks that have IBS. So, basically here, there's 3 phases in the FODMAP diet. First phase is elimination. The second phase is reintroduction, and the third phase is personalization. So what will happen is in the elimination process, it's commonplace for folks with IBS to eliminate the foods that serve as triggers. Well, actually, in this process, you're eliminating basically all high FODMAP foods. As you can see in this here, diagram, or in this table rather, you're seeing fruits, you're seeing certain vegetables, grains, legumes, nuts. Basically, all of these foods that are not recommended in the top portion, right? Not recommended. All of that is going to come out of your diet. Once those foods are taken out of your diet, right? Once you've, gotten, the foods that are recommended for you to take, you'll take those foods, you'll eat it, and then what will happen is the reintroduction process then comes into play. So phase 2, that's basically where you're going to be reintroduced some of the foods that were taken out in the first place. So some of the, fruits, veggies, grains, things like that, they're going to be reintroduced into your diet. And the reason why that happens is, the goal is to see which of those foods act as triggers for those that have IBS. That may be, worsened symptoms, abdominal pain, cramping, diarrhea, constipation, the like. Personalization that comes into play, that's phase 3. So a personalized diet of sorts is essentially what's going to come after that, right? So all the foods that serve as triggers for your IBS, you're going to be told usually by a doctor to avoid those foods. And, the foods that don't really cause triggers for you or don't act as triggers, those are the ones you'll likely, be able to have. That's how the FODMAP diet works. So the high FODMAP foods are going to be taken out. You'll be put on a low FODMAP diet, essentially. In the elimination process, the foods that will get eliminated, the foods that are not recommended, they'll get eliminated for roughly about 2 to 6 weeks to start off with. Because about 2 to 6 weeks, that should be enough time usually to alleviate all your symptoms. Right now, as it stands, IBS is it's incurable, so there's nothing you can really do about it once you have it, but it is manageable. Okay, you can always manage the symptoms. So that's really the only thing you can do if you have IBS. If you're dealing with this, I tell you, my heart goes out to you. I actually know a couple people that have this. I can only imagine that it sucks because, there's certain foods that you just unable to eat. It's almost like, especially with GERD and even celiac disease, right? Celiac, basically anything with gluten. Those people who have celiac disease can't eat anything with gluten in it. So if you ever, are around anybody who, asks for anything gluten-free, likely that's why. They may have celiac disease. I mean, maybe not. Maybe they just don't like gluten. That's a possibility too. But folks who have celiac disease, they can't eat any gluten. Wheat, barley, rye, usually those are the things they have to stay away from. It's never a good thing, man, when you can't enjoy the full, you can't enjoy full life like that. You know what I'm saying? Maybe you want to eat certain foods, dairy, you want to eat maybe a cheesy pizza or what have you. Maybe you want to eat certain, even fruits, right? Like even in that diagram or that table I showed, certain fruits like apples and apricots, ripe bananas. You can't really have any of those, you know what I'm saying? Or at least those are the foods that'll get taken out, and make the not recommended column. Versus, you'll be able to eat certain berries, blueberries, and cantaloupes, things like that. Those are the foods you can eat. So it always sucks if you happen to be the type of person that likes certain types of fruits and vegetables even, which are for the most part healthy for everyone, for the average individual. But if you happen to have IBS, even certain fruits and vegetables you're not even able to eat because they can be triggers. And that right there will put an end to 302B. This has been Irritable Bowel Syndrome. I hope y'all enjoyed this. Hope y'all got some good info. Hope this was of value to you. And if it was, give me a like, and feel free to comment if you have any, comments, questions, concerns, and definitely give me a subscribe. 302C is going to conclude this mini series for digestive tract disorders. So y'all take care. Have yourselves a good one.